Thanks for the opportunity to speak about interventional heart failure. When I was a fellow in training, Joe Lascalzo came and gave us a lecture about the priorities for cardiology fellowship training. And he described this concept of the 5 Ps. And these were patient-centeredness, persistence, patience, practice, and this term perspicacity, which is defined as a clarity of vision or intellect which provides a deep understanding and insight. And it was this last term that really caught my eye, primarily because what he was asking us to do was not only train with the current patient in mind, but also starting to think about the future and what the future might look like for patients and how we could be prepared to manage those patients in the future. And around the same time, it was becoming very clear that heart failure is a massive epidemic. And in fact, all patients entering the cath lab already have developed or are at risk for developing heart failure. And this was enhanced by data coming from Hemodynamic in 2013, which said that by the year 2030, 1 in 33 individuals in the United States will have heart failure. So it's pretty clear to me as a budding interventional fellow that getting a better understanding of my patient population meant I really should understand heart failure. What I started to also realize is that every interventionalist is a hemodynamic specialist. And while I was learning about acute load, compensatory hypertrophy, systolic failure, and dilated cardiomyopathy, all of these different clinical substrates were entering the cath lab. And that's when I started to realize that actually the hemodynamic substrate is what drives us as interventionalists. And a more recent review article from Doug Mann in 2012 identified this idea of myocardial remission as well as myocardial recovery. And this started to link the concept of cardiac remodeling with hemodynamics and thinking about pressure and volume. So I started to realize that penetrating insight into hemodynamics opens new opportunities for interventions that are tailored to the heart failure patient. Now, a number of years later, we've developed the Robert Kung Interventional Heart Failure Program at Tufts Medical Center. And the mission of this program is to advance the training of the Cardiovascular Center fellows by providing interventional fellows with an opportunity to train in advanced heart failure and cardiac transplant medicine, thereby combining technical and cognitive skills to optimize inpatient and outpatient care, advance new approaches for clinical research, innovation, as well as education. And you can see in the bottom left, the House of Interventional Heart Failure has a number of different rooms or domains where an interventionalist can intervene or start to make a difference for patients with heart failure. Now, this house is also built on the foundation of device innovation, which is coronary and structural, as well as invasive hemodynamics. And this goes from basic all the way to advanced hemodynamics. So for this reason, we created this 5-year track, which allows our general cardiology fellows to complete their training, and then they enter an ACGME certified year for advanced heart failure transplantation, and then they end with interventional cardiology as another ACGME year. These are now fellows who are board eligible in both advanced heart failure as well as interventional cardiology. Now, there are a number of different domains that I think are readily apparent for interventions in heart failure. One that you're very familiar with is complex coronary revascularization. Our fellows see a substantial number of patients who come in with low EF situations who are requiring revascularization, often turned down by cardiac surgery, and as a result, we're left to do complex PCI. Another domain relates to valvular heart disease. We're seeing a significant growth in our approaches for mitral as well as tricuspid therapies. The COAP trial was a landmark study that really bridged the gap between interventional and heart failure, both for DMR, but now introducing functional MR. And these are really very important and unique hemodynamic substrates where I think having a background in advanced hemodynamics and heart failure management really comes into play. The other area for valvular heart disease, of course, is around aortic valve replacement. Now, this, of course, can be done for patients with normal EF who have valvular heart failure, but also is more complicated in patients with low EF who actually also have concomitant valvular disease. And as a result, this is another important area where that advanced training in heart failure comes in handy. Hypertrophic cardiomyopathy is another dominant area in interventional heart failure. We know that a lot of these patients are sent for surgical myomectomy, which is first-line therapy for a number of them, but a lot of patients are not candidates for that therapies, and as a result, alcohol septal ablation is another approach for these complex hemodynamic cardiomyopathic patients. Now, the importance of interventional heart failure, I think, also is covered by the spectrum of outpatient to inpatient heart failure management. Oftentimes, as interventionalists, we're introduced to a heart failure patient when they're first developing heart failure by having their first acute MI. These patients may or may not present in cardiogenic shock. A lot of them may survive to discharge to the hospital, enter the heart failure clinics, And here they have recurrent admissions for acute heart failure episodes. And in each of these admissions, they are passing through the cath lab for hemodynamic assessment, for revascularization, for valve interrogation, et cetera. And then ultimately, on the other end of the spectrum, these patients come back to the hospital in advanced dilated cardiomyopathic states. They also, again, undergo high-risk PCI. They may be in cardiogenic shock requiring advanced therapies. And these, again, are those advanced heart failure patients where that knowledge base comes into play.
Well, there are a lot of people
now,
who
over the
don't
past
believe that the
few
pumps do
decades,
anything.
we've also seen a massive growth in the use of mechanical circulatory support. This is one of the most exciting fields, I think, in interventional cardiology. But I think as the interventional heart failure fellow, you're also trained to not only make decisions around short-term MCS, but also around durable MCS. And
Well,
a
there are
lot
a lot
of
of
the
people who
practices
don't believe
that
that the
you
pumps do
implement with
anything.
durable VADs can actually be crossed over and applied to the short-term MCS environment as well. We've also more recently been intervening on the machines themselves. This is another area of advanced VAD interrogation as well as intervention. This is an algorithm that we put out more recently about outflow graft obstruction. How do you evaluate these patients? How do you manage these patients? We've also seen valve interventions on patients who have LVADs who either the LVAD has failed or they've developed severe AI and require valvular therapy. Now, short-term MCS is also growing. This is a really interesting area that I think over the past few years has really forced us to go back to our fundamentals in hemodynamics because of the introduction of right heart support and also the utilization of VA ECMO. These are very, very complex physiologies that we're dealing with, and a thorough understanding of right heart failure as it relates to the heart failure patient, whether it's acute heart failure or chronic heart failure, is becoming very apparent that the interventionalists are playing an important role for these patients as well. And you know, I can tell you from my own clinical experience that fundamental knowledge of durable VADs has really helped me understand acute mechanical support. When I learned about HQ curves and this concept, this was around LVADs, but I started to realize that actually the interventional community doesn't know much about HQ curves, how these devices work in terms of their flow regulation through a transvalvular gradient. And this became very instrumental in helping me understand and manage my patients with cardiogenic shock or patients undergoing high-risk PCI who need mechanical circulatory support. And finally, I think another area of growth is in managing the ambulatory shock patients. One of the most important aspects of IHF training is the ability to define and successfully bridge patients to exit strategies in advanced heart failure. And equally important is the ability to identify patients who are not candidates for advanced therapies. And this, I think, is a critical point for the heart failure fellows, is we're trained to essentially say that this person is not an MCS candidate. And I think this will really help the interventional community quite a bit when the interventional heart failure person can actually say, based on all this experience with heart failure, this person should not get short-term MCS. And then finally, there's a lot of growth and excitement around emerging devices for heart failure. This is a recent review put out by Hannah Rosenblum and Daniel Burkhoff describing some of the technologies that are emerging for heart failure. And all of these technologies are applied in the cath lab. So I think the future for interventional heart failure is bright. There's obviously a lot of patients who are in desperate need of this type of advanced training with their physician. And then also these devices, I think, are really critical as we start to evaluate their utility in patients with heart failure. Requires an interventionalist who not only has the technical skill, but also has the cognitive background in the field of advanced heart failure. So I believe that innovation occurs when you cross-pollinate from one field to another. Interventional heart failure is a great example of that type of cross-pollination and allows us during training to get that type of perspicacity that's needed to move the field forward and advance care for our patients. Thanks very much for your attention.